Kristen. I'm here at UT Southwestern Medical Center, and I'm excited to be here today with interventional cardiologist Dharam Kumbhani. And Dr. Kumbhani completed his internship and residency at Hospital of the University of Pennsylvania and cardiovascular training at Cleveland Clinic. He also completed a postdoctoral fellowship at Brigham and Women's Hospital and Harvard Medical School. He specializes in advanced interventional cardiology techniques and is currently the director of our interventional cardiology program here at UT Southwestern. So as usual, don't forget to like and share our chat with as many people as you can. We want to get this message out as wide and far as possible. We can't answer, Dr. Kumbhani can't answer really specific medical questions, but we'll certainly take as many as we can get to in the next 20 to 25 minutes. So we're glad you joined us. Dr. Kumbhani, thank you for joining us.
Thanks for having me, Kristen.
Should be a great discussion. I want to get started with a question that I hear a lot when people talk about interventional cardiology. Many people don't know what that means. So what does an interventional cardiologist do?
Yeah, it's a great question. So interventional cardiology is a subset of cardiologists. We are all cardiology trained and cardiology physicians. But then we also specialize in, doing things with stents and balloons. So opening up blockages. And that's kind of, I guess, the principal essence. So whether that's blockages in the heart, that need stents, whether that's, valve blockages that need, some newer advances we'll discuss in a little bit, or, blockages elsewhere as well in the legs and things like that. And so we're really specialized in trying to open up blockages and help symptoms.
Okay, good way to start. So when we talk about interventional cardiology, there are a number of procedures. I've heard a lot lately about TAVR, and so I'm wondering, what is TAVR and who is eligible for that procedure?
Yeah, it's a great question. And so TAVR, for those of you who may not have heard of it before, is Transcatheter aortic valve replacement. And it's really one of those revolutionary technologies that has really come into the fore in the last decade or so. We've had a very successful TAVR program here at UT Southwestern. We've had a program here for nearly 7 or 8 years. And we've done more than 300 patients now with this novel technology. And we have some of the best outcomes in the country for that as well. So what the procedure is basically it's an alternative to aortic valve replacement, to surgery. And so it's a program that we've run very successfully with the cardiac surgeons. So typically these are patients who are a little bit older, have some other medical problems that may make surgery higher risk. I think the gold standard for many people is still going to be surgery. And we have many excellent surgeons that do surgery to fix that. But then I think for higher risk patients, TAVR has been a very exciting alternative where we can do the entire surgery. It's beating heart surgery. We never stop the heart, and very quick recovery. And as I said, very good outcomes.
Okay, now it's not the only option. I know we talked earlier about MitraClip. That's also, is that an option if TAVR isn't the best fit for you?
So it's a good question. That's a slightly different procedure. It's for another valve.
Okay.
So what's happened now in interventional cardiology is now there are options, what we call percutaneously or without cutting anyone open, that we do in combination with the surgeon. So TAVR is for the aortic valve. It's a percutaneous option for that. The MitraClip is a percutaneous option for the mitral valve. That's another valve in the heart. And it's not a replacement like TAVR, which is you put a new valve in. MitraClip is a procedure which helps people who have a lot of leakiness in the mitral valve and who are high-risk surgical candidates. So again, we've had a very successful program here with the surgeons. And a lot of people that have this problem are actually going to be really good candidates for surgery. But in those in whom surgery is either high risk or prohibitive, we've had a very successful MitraClip program as well.
Okay, good to know. So I see the questions coming in. We've got one from Tony and we have one for Christina. So your questions are up next. We're going to start with one from Tony. You mentioned balloons and stents. And her question is, how long do balloons and stents typically last?
Yeah, that's almost a quintessential question for the field. And I think it depends on the context. And I think it depends on, where we use them. So I think, for example, if we use it to open up blockages, someone's having chest pain and you open up the blockages, we've come a long way just in the last 20 to 25 years. The stents that we have these days are, really state of the art. The risk of narrowing down and having what one would consider failure, basically having scar tissue that kind of, would make another procedure perhaps necessary, is low, is around 5% or so. But I think it depends on the context. It depends on whether they have diabetes, whether they have kidney disease, that kind of thing. And it depends also on how many blockages and how many stents you end up putting in. So, we do, hundreds of these procedures a year. And, the success rates have been very, very high. The immediate success of being able to do that is very high. And typically, just so that everyone's on the same page, if people have a blockage, the first step is we put a wire across it.
Okay.
And then we balloon it open. And then a stent is just a metal cage that keeps it open. So almost invariably, the balloon and the stent, they are in the same procedure.
Okay.
And the stent portion is what increases the longevity of these procedures.
Okay, good question, Tony. Thanks for joining and thanks for asking the question. Now we're going to go to the one from Christina, and this is an interesting question. It's, can patients who had PFO closure scuba dive? If so, up to what depth is safe?
So that's an excellent question.
I like to scuba dive, so that would be.
Yeah, so, in general, so we do, that's one of the things that's in the armamentarium of interventional cardiologists. All the valve procedures, the PFOs, they're now kind of becoming even a subspecialty within interventional cardiology called structural heart interventions. And so PFO closure is one of them. So, PFO is basically you have a hole in the heart, and that's allowing, small bubbles to go across from the right side to the left side of the heart. When I say bubbles, I mean that on the echo, but in reality, there's a small communication between the right and the left side of the heart, which shouldn't be there. And so, typically the closure is indicated for patients who have a stroke, that this actually causes. PFOs are very common. About 30% of the population, on this planet has them. So they're not necessarily a cause for stroke in themselves, but in younger patients, we see that. The scuba diving question is very interesting. So there are very small subsets of patients where even if they're not having a stroke, considering a PFO closure is indicated. And so scuba diving is one of them. I think if you've had it closed, it typically takes about 6 months or so once you've had it closed to get new skin on it, or what we call endothelialize. And so once it has a new skin, then it's no longer a foreign body, and that hole is completely sealed off. And so I would think that if it's been in that long and there's been no issues, and the follow-up looks good, that it should be safe after that. I'm not sure if there's a particular depth that is prohibitive after that, but it is true that sometimes we worry about patients who do that, for example, as an occupation.
Right.
That in theory they may be more likely to have, especially bends, is what people worry about when they're coming up.
Absolutely. Really interesting question. Thanks for bringing it up. And we've got another one here from Jenna, and her question is related to interventional cardiology. I'm curious if this is possible for polycystic kidney disease patients. She's read that valve issues are common with PKD patients. Is there an interventional approach maybe for PKD that you're aware of?
Not directly, not that I'm aware of. I think you are right in that there may be some overlap between patients with polycystic kidney disease and certain other conditions, but there isn't an intervention that I know of that directly would treat the polycystic kidney disease. And I think it's probably best assessed in clinic to kind of see what else, is there.
So it's a good option to call and schedule an appointment, perhaps. Yeah. Okay, thanks for joining us, Jenna. We have a different one here from Carter, and this gets back to TAVR, which we started with. And does that procedure require general anesthesia?
Excellent question. So yes and no. I think we've done it both ways. So just to be clear, the TAVR procedure for the aortic valve is beating heart surgery. So we don't actually stop the heart. The patient never goes on the heart-lung machine. The anesthesia portion, it kind of depends on the scenario. We've done it both ways. So we've had patients where it's safer to do the general anesthesia, and we've done it that way. And then typically we get the breathing tube out right after that. There are a lot of patients that we've done where we do it with what we call deep sedation. So they're asleep and they're obviously not feeling the procedure, but they're still breathing by themselves.
Okay.
And so I think it can be done both ways, but I think the context is important.
Okay. Now we've had a couple questions about TAVR, and I'm wondering, when you talk about replacing the valve, is there an average time frame that a valve lasts? Do you have to go in and do it again later?
Yeah, so that's, again, that's something that is actively being studied right now. So, these valves there are two valves that are commercially available. We use both of them. There's one valve which is called the Edwards valve, which is made of cow tissue, and the other one is a Medtronic valve that is made of pig tissue, pig valves. And the valve portion of this is identical to what is used for surgery. Okay, so when the surgeons stitch the valves in, the only thing that's different is they have a sewing ring where they can put the stitches, and our valves come inside a stent, so we put them in without stitching. But the valve, the thing that opens and closes, is the same. It's made of animal tissue. The surgical valves, in general, they last about 10 or 15 years in general. Now TAVR, we're still finding out. It started out as a procedure really for people who couldn't have surgery. Okay, so the longest follow-up that we have is in this patient population that they couldn't have surgery, and so up to 5 years these valves function just as the same as surgical valves. We're now using them in lower risk people, and everyone believes that the longevity is going to be the same as surgical valves, which is going to be 10 to 15 years, but that's yet to be proven.
Interesting. Okay, so some more work to do on that.
Yeah. And I think, we haven't seen any signals of, great harm, something, catastrophic happening at 6 or 7 years. We haven't really seen that. So, and in Europe, for what it's worth, the first valve was implanted in France. And so Europe has a longer experience with this. And we don't believe that it's going to be, and there haven't been any signals from Europe either. So, but the jury's still out. I think what I normally tell my patients is, up to 5 years, we can guarantee that the valve is going to function just as well as a surgical valve, and it'll probably just as good, but we still need to figure that out.
Okay, great questions. These have all been great questions. We're already about more than 10 minutes into our chat, so if you have questions, keep them coming. Be sure to submit them now. We do have one from Carrie, and her question is fairly specific, but it's, can you replace my TAVR if my valve degrades in 10 to 15 years? It sounds like yes.
You can. So there's, again, I think the context will be very important. But I think, if you got a TAVR because you were not a surgical candidate or considered a high-risk surgical candidate in, let's say, 2019, then you're certainly not going to be a surgical candidate in 10 years or 15 years. Okay. So, but there have been situations where, TAVR valves have gone bad that happens with surgical valves as well sooner. And we've been, we can put in another TAVR valve inside that. But I think the dimensions are important, what kind of valve, the anatomy becomes very important there. But in theory, to answer your question, it is definitely possible, but I think the context is important.
Okay, great question, Carrie. Thanks for joining us with that. And we've got another question here from Ellen. And this is a very good question as well. And that's, how does a patient and their family prepare for somebody to have this procedure? Are there anything that they need to do in advance?
Well, I think, so I want to make sure I address the question directly, and I'll maybe just talk generally, and then you can let me know if there's anything else. But typically, so our workflow, for example, at UT Southwestern is, we see the patient and the family in what we call valve clinic, where we see pretty much all patients who have valve problems, and that's what I run and direct over here as well. And we see patients with the surgeons, and beyond just the people who do this, there's a whole army of nurses, PAs, etc., that are involved with screening and figuring out who is the right candidate for this procedure. And so everyone meets the patient and their family on the same day. So it ends up being a long visit, but it ends up being just one visit before the surgery. And then there are certain scans, etc., that are needed to plan for the surgery. And again, all of that happens on the same day.
Wow.
And so, so then when we meet them, we typically have very long discussions because now we know a lot about them, not just about their history, but also based on the scans, what they look like from the inside, so to say. And so then we have, long discussions about, this is how we're thinking this through, this is what we're looking at. And then, a lot of times that may be if they've already had a lot of the other workup done elsewhere. And, we get patients from out of state, for example, and, a lot of the workup is done elsewhere. And then they'll meet us for the valve discussion. And then a lot of that is, kind of understanding what they're signing up for, understanding what the procedure entails, and then kind of going from there. And then, we have a dedicated valve coordinator. Her name is Dawn, and so she meets people on the day of this visit. But then, everyone also has a phone number. So if something comes up, you go home and you say, oh, I meant to ask you that. And then, it's easy to call her or us and, discuss that as well.
That sounds great. That you can get it all done in one day and meet with all of the people that are necessary and required. Okay, really great question, Ellen. Thanks for bringing that up. So related to valves, Crystal's question is you mentioned there, cow valves, pig valves. Is one valve preferential over the other? Does it depend on the person, I'm guessing?
Yeah, I think, again, it's a great question. I think our experience is, and we've been doing this pretty much from the time that they were commercially released in the US. And so we have great experience with both the valves. And I think my guess is about 70% of patients, either valve is about the same. And then the other, 30%, there are certain anatomical reasons why one may be better than the other. But I think, all the studies, there's, some minor differences between the valves, but for the most part, as far as performance and, length of stay in the hospital and things like that, they're very similar. Okay,
good question. So here's one from Lori, and we have about 5 minutes left, so get those last minute questions in. But one from Lori is, can you have a valve replaced and then return to a normal life similar to the activity level that you had before, or even better?
Well, I mean, that's one of the goals of valve surgery. So I always tell my patients, the reason to do something is either it's going to make you live longer or it's going to make you feel better. And so I think valve surgery typically, or valve replacements, they typically achieve that. A lot of patients are very symptomatic from these valve problems, and they're actually not benign. They're fairly lethal problems. They estimate that once you have severe aortic stenosis, more than 50% of patients will die within 1 or 2 years. It's a very rapidly progressing disease. And the irony of that is the valve replacement is curative. It's not just you're trying to patch something, you're actually curing the problem. So yes, and again, but the symptoms are important. If it's my experience, if it's more fatigue and less specific symptoms, then those may or may not get better. But typically, valve problems cause shortness of breath or chest pain, and those almost always get better.
Okay, sounds great. Thanks for the question, Lori. Here's one from Jenna, and this was similar to my question, so I'm glad somebody asked. But on average, how long does the surgery take? I think either if we're talking about MitraClip or TAVR.
So again, it's a good question. On average, I would say they last 3 or 4 hours. And that includes, the time the patient gets in the room. It's not we do these in the hybrid operating rooms. And so the time the patient gets in there, anesthesia puts in all the IVs they need to put in. If they need to go to sleep, then, the time for that. Skin to skin, the time that it takes us to put a new valve in is typically 90 minutes or 2 hours or so. It's pretty quick. Yeah, it's pretty quick.
Really amazing.
Yeah. And the recovery is very good as well. Typically, patients go home in 48 to 72 hours. It's really incredible.
That was actually the next question, was how long is the average hospital stay?
So our median here is about somewhere between 2 and 3 days, so just about that. And obviously there are some people who need to stay longer. It really depends on what shape they're in coming in for the surgery. But on average, our patients go home in 2 or 3 days.
Okay, great questions. I think that last one was from Carrie, so thank you. Now we're running out of time here, but I want to just get a couple quick questions in. And one is about, you mentioned symptoms very briefly.
Yeah.
But what are some symptoms that people should definitely be cognizant of and either speak to their primary care physician or talk to a cardiologist?
Yeah. So the most The most prominent symptom of valve disease or valvular heart disease is shortness of breath. That is by far the most common symptom. Now, it's also very non-specific. It could be from a number of things, including other things in the heart. It could be from high blood pressure. It could be from having blockages. But shortness of breath, if the converse is true, if you have valve disease and then if you have shortness of breath, unless there's another cause, then you really have concern that it's from the valve disease. Some people can have chest pain or chest heaviness. Lightheadedness or passing out is another kind of concerning symptom. And then some people may just have palpitations or things like that. But I think any of these symptoms, it's very reasonable to go to primary care or have a closer evaluation for that.
Okay. Well, I think we are just about out of time for today's chat. I want to thank everybody for all the comments and the great questions. I know Dr. Kumbhani needs to get back to clinic, so thank you again for joining us. Thank you for taking the time to answer all these questions.
Yeah, thanks for having me.
Absolutely. So as usual, the chat will be here on Facebook later today, and it'll also be on our YouTube channel. So please share it with your friends and loved ones who have questions about TAVR and interventional cardiology and all the other topics we talked about today. In the meantime, have a great afternoon.